Snorers, people with sleeping disorder breathing problems tend to put on more weight, and obesity and large neck circumference have been shown to be intimately related. And there's lots of evidence-based research that shows the cause-effect relationship between an emerging or elevated apnea index and weight. And as you gain more weight, your apnea index can go up. Conversely, if you get this problem under control, you'll notice precipitous weight loss in many cases, along with an emerging increasing level of energy. But as a guideline, if someone says, yes, I snore, and you ask that because they clench their teeth and they're showing recession, all those things that seem so unrelated to sleep, and you see they have a large neck, or he or she does, they open their mouths and that tongue just fills the whole room. It has all the ridges on the side, it's scalloped. Again, your level of suspicion that might be a problem should go up. SGS is a company that really supports this type of attention to patients. There are screening forms available through that company on their website. Part of that terrific form they utilize is the Epworth Sleepiness Scale. And basically, it's a very simple screening tool, and I'll have more of these available for you to download in the future. But suffice to say, if you have your patient in the reception room, they're going to sit there another 2 or 3 minutes because while they're getting their teeth cleaned, you notice that they're cracking a lot of fillings and they've got a lot of class 5 abfractions, and they say, yes, I snore. All you have to do is give them this Epworth Sleepiness Scale to fill out, or the Sleep Group Solutions screening form that you see here on the slide. And if you see a lot of yeses, look, there might be the potential for a problem. And taking the next step is not that difficult. It might mean just referring it to, just calling it to the attention of their primary care physician. You may very well know a pulmonologist in your area, and they don't like new patients. And you can just say, look, I think you need to have this looked at, and take the screening form with you. Pardon me. Or you may, if you're involved in this process, if you see TMD patients, what we do in our office when we got involved, we made an investment, and we invest in airway acoustics. And that's a lot of the reason why I'm here today, because I believe in this technology, and it's moved our practice down the road so far, and particularly in the management of orofacial pain. And when I understood its applicability in managing people with sleep disordered breathing, we got real excited. But with airway acoustics, and you're looking at a pharyngometer and rhinometer right now, this has been used for many years by pulmonologists and ENT doctors, and we see greater applicability in dentistry now. You can use this instrumentation to further screen your patients, and if you decide to get in the game and treat people with sleep and disordered breathing problems, you'll start to understand how this technology can make that a very efficient process in your practice, and much of it can be delegated very effectively to qualified staff. Pharyngometry and rhinometry. Pharynx means your airway, your upper part of your airway, and rhino refers to your nose. Why are we interested in looking up a nose with sound waves? You'll just have to accept this on fact that if you can't breathe through your nose very well, it affects how you develop, especially with children. You know, mouth breathers tend to have long faces. They have downward growth of the jaw, which means they have further descent of the hyoid bone. And these kids have bad bites, and they tend to have more apnea-hypopnea events because as the farther that hyoid bone descends, the more collapsible and narrow their airway is. So rhinometry is a way to look to see if your attempt to help these people with their sleeping and breathing problem, even with their TMD problem, is going to work. Because if you have a narrow, high upper airway, Bernoulli's principle, don't ask me to explain it, but if you've got a collapsible tube and you've got a lot more, you have resistance to movement of air, it causes collapse down below. That's about the best I can describe it, but look up Bernoulli's principle and look up rhinometry, and you'll get, if you just Google that, you'll get a lot more information you could possibly use. But suffice to say, looking at the nose and assessing someone's ability to breathe through the nose, easily or not, will impact your ability to help these people. And it's easy to see with the printouts and the graphs that are obtained if there's a problem or not. You're just comparing one side to the other. You're comparing the cross-sectional diameter of the high upper airway before and after decongesting, and you'll get a graph, and it will tell you in an instant if there's resistance to breathing through the nose. And if there is, and if these people have fatigue, if they're sent to you because they're CPAP intolerant and some physician wants you to make them a sleep apnea mouthpiece, you want to know if the nose is patent or not. If it's not patent, you're going to have a problem getting the airway of their pharynx dilated sufficiently, because the high upper airway, if it's not patent, will cause collapse of the lower airway, if you will. And these landmarks are easily identified. Pharyngometry. Pharyngometry, the pharynx, the oropharynx, the velopharynx, the part we can look in, and our playground every day, can be evaluated as well. In using pharyngometry, it's a very quick process. It's painless. It's very inexpensive to do this on a patient, because you're basically putting sound waves down their nose or down their throat, and it's bounced back, and there's an algorithm that takes that information, and it gives you a graph, and you can see in real time, instantaneously, if their airway, if the tongue's too big for the mouth, if their airway caliper is sufficient to accommodate a healthy life, and you can see in a moment, by moving that jaw around in real time, if that airway will respond to mandibular repositioning. And so with pharyngometry and rhinometry, you can very quickly determine if you might have a role to play in the management of a sleep and disorder breathing problem. I'm going to assume for a minute that you have a level of interest in treating people with these sorts of medical problems for which they can't receive proper medical care because they can't tolerate, for example, CPAP. And you will find that this technology allows you to more accurately assess and predict, in my opinion, who might likely respond to treatment. And we use it all the time in our regular dental patients who could care less or know anything about this before entering the office that day, until I see that those cracked flat teeth, or those abfractions, or that recession, to which there's no other good explanation. And when I ask that question and they say yes, they're introduced to a world of technology that might really help them and not even realize that you're available to them. Anyway, pharyngometry landmarks are easily identified, and you can see in a moment how these will change when you move that mandible around. It's very interesting when you look at pharyngometry in live time. You'll see the airway collapse at many levels, not just where the tongue is. Most people, like I did, they think that all the problems in the world are collapsing where the tongue is, because if you have a big tongue, you're going to have sleep apnea. So why not just do surgery? Well, that's what we used to think, but until we had real data, we didn't know better. We know that about 80% of the time, airways collapse not just at the tongue, but below the tongue in the hypopharynx as well. And so we now know, with this knowledge, when to refer and not to refer for surgery. And surgery generally is woefully inadequate for a lot of sleep apneics because of this concept that they collapse at more than just the area they can get to surgically. In some instances, yes, you can pick out people who are more likely to be responsive to surgery and help prevent a big problem. I'll just make another comment about pharyngometry. The way we use it in our practice of dental sleep medicine is we'll get an appliance ready, and we'll have them advance their jaw, and using pharyngometry, we can see at what position we need to move that jaw towards before the airway dilates and remains stable. There are a number of portable monitors that are available, and we have a series of them On here you can see the Aries, the Snap, the Embletta. These are very easy to use. They're done at home, and people can sleep with these monitors. And depending on the type of monitor you purchase, you'll receive a certain level of information. Some of these can be used for making a diagnosis of sleep apnea, a hard diagnosis which will open up medical benefits for that patient for which they can receive treatment. It has to be done under the guidance or the support of a qualified physician. That's how it's being done at this moment. But these are also excellent if you're trying to get people treated sufficiently who have been referred to you, for example, because they're CPAP intolerance, to have these monitors available so you can see how close they are to getting a full response or not to your mandibular advancement device, saves them a trip back and forth from the hospital and wasting a lot of insurance dollars because you haven't quite got to that end point in titration. Suffice to say that portable monitors are being utilized and have an emerging role in the diagnosis and management of sleep disordered breathing, particularly in the dental sleep practice, where monitoring, because the appliances we use have to be titrated over time, is very efficient and very effective. Well, why even mess with this? CPAP works. I mean, you know, I've been told that's the thing. Well, you know, Dr. Colin Sullivan from Australia, who got this thing going back in the 80s, he had a great idea. And CPAP works 100% of the time when you wear it. The fact is that CPAP, for a lot of people, is difficult to wear long-term because of the restrictions to sleep and movement, the straps, the claustrophobia. I can't breathe through my nose. I'm a mouth breather. It is truly a godsend when it works because it works so well. But what about, let's say it's 30%, 50%, I don't know, whatever. Let's say, what about the percentage of people who have sleep apnea and can't tolerate CPAP? And depending on the research that you accept, it can be anywhere from 80% down to 20%. Okay, well, those folks who can't tolerate treatment, surgery doesn't work about 70% of the time, and they don't want a tracheotomy yet. So what are their options? Well, a lot of people think, and the research, the evidence-based research shows that for mild to moderate sleep apneas, for UARS, the sleepy snorers, and for snoring just in general, oral devices work very, very well. But CPAP is more efficacious. I mean, why don't we just, CPAP is more efficacious, it is more effective, but it's not tolerated well by many people. And so if it doesn't work for them, and oral devices are very effective, we're obliged to make that knowledge available to people so they don't die from their disease. Sleep apnea will lead to a lot of medical problems, heart attacks, strokes, and a lot of suffering along the way. And so we're compelled to get the word out that just because you're CPAP intolerant doesn't mean you have to die from the disease because nothing else will work. CPAP works well. A lot of people have a hard time with it, and that's just a fact. And I wish it were otherwise, but that's the way it is. Again, CPAP compliance or people hanging with it, the numbers range tremendously, but I would say it's safe to say that most people would agree that half the people can't handle it and half the people love it. And so for the 50%, in my opinion, of the group who can't, are we going to write them off? No, we don't have to at all. We just have to understand that we have a role that we can play in managing this medical problem. And it's oral appliances. Oral appliances can be very effective in treating and fixing a lot of these problems. We'll say the mild to moderates often respond very well, and it's a fix. For the severes, maybe half of those people will get significantly improved from oral appliances. And for the balance of people who don't get sufficient healing, We know it's about 7 to 1 that people prefer oral appliances over CPAP, and that's not knocking CPAP. That's just they can tolerate it better. And of the people who don't get enough healing from oral appliances alone, we can work with the sleep doctor and make the pressure requirements for CPAP therapy much more tolerable by virtue of wearing a mouthpiece concurrently with the CPAP. Because if you have the airway halfway open, the pressures required to get it the rest of the way are significantly less. And there are some devices now that you can connect to the mask, or you can even make a customized mask yourself, and you can learn how to do that, that hooks to your mouthpiece, that stabilizes such that you don't even need straps. You can be on your side, in any position, and the mask will stay in place and won't leak. So oral devices have a huge and, believe me, emerging role in managing these problems. It's bigger than I've got time to discuss today. And I could go on, and I'll be rambling, but suffice to say, if you're in a practice and you have any TMD patients at all, if you have kids who are at least a bit hyperactive, if you have any adults who just can't seem to lose weight, and if maybe a couple this year have recession that you can't understand, never mind the person just sent to you because they can't manage CPAP. There's a whole lot out there, and you owe it to yourself to gain more knowledge about the role that dentists play in the management of these very troublesome problems. Thank you.